Here are my disclosures. Great. So for our presentation today, hopefully be able to answer the following questions as part of the presentation. Who should be assessed for possible dementia? What are some of the key steps when assessing someone for dementia? And what are some of the key supports, non-pharmacological and pharmacological treatments for people who are recently diagnosed with dementia? Dementia is a huge topic, so we're not going to be able to cover everything today, but hopefully the basics of the assessment and initial sort of management of people with dementia. And just to talk a little bit about the best practices and guidelines, much of what I'm going to be talking about today is going to be from the Canadian Consensus Conference guidelines on dementia. Not going to go through these in detail, just to say that in Canada, we've had excellent dementia guidelines going on for over 20 years. The most recent ones have just been updated this past year. And so I'm going to sort of highlight some key recommendations from these guidelines that are important for assessment and management of dementia. And I'm going to follow a sort of stepwise approach from a project that I was involved with that took the dementia guidelines and made some clinical pathways. I would say there isn't a right or wrong way to go about assessing dementia, but there are some key steps. And I think these types of pathways can be helpful in just sort of helping you remind yourself of what are some of the key steps and ways to sort of go through the evaluation of someone who may have dementia. And then there's a separate pathway here for the initial management from when someone's been diagnosed to initiating treatments. So why is it important to assess cognition in older adults? I think, for most of us, it may seem obvious, but sometimes there can be a little bit of pessimism about, well, why should we bother? Is there anything we can really do? And there's a number of reasons why it's important to have an approach to evaluating cognitive complaints. Cognitive complaints are very common in older adults. It's important to establish whether there might be a diagnosis, either of dementia or another condition. To assess the cognitive impact of things like psychiatric or medical conditions and evaluate changes over time. It serves as an important communication tool between healthcare providers, and really cognition is pretty integral to autonomy and safety. And so it's important to have a way to be able to assess it to keep our patients safe and functioning as independently as possible. In terms of dementia, there's about 500,000 Canadians who are impacted by dementia, and with the aging of our population, it's anticipated that this number will double given the number of older people who will be in Canada over the next generation. And the strongest risk factor for dementia is age. So the chart you see here lists the prevalence of dementia in different age groups, and you can see that by the time you get to over age 85, about 1/3 of people will have some degree of dementia. So age by far is the most strong risk factor. But maybe we'll just kind of throw it into the chat here. What are some of the other risk factors for dementia that people should be thinking about? Yeah. Great. Yeah, some great ones here. There's a lot of different risk factors. So here are some of the common risk factors or protective factors for dementia. So things definitely like head injury, I saw in the chat, cardiovascular risk factors, things like obesity, smoking, diabetes, depression, sleep changes are risk factors. Things like education, the more education you have, the less likely you are to have dementia, physical activity, Mediterranean type diet. These are all protective factors. I think all the other ones I saw in the chat box were all risk factors as well. Not all of them as common as these, but certainly there's a number of different risk factors. And when we look at these risk factors, a lot of these risk factors are preventable potentially or modifiable. So up to 40% of cases of dementia are preventable. And the diagram here shows that at different phases in someone's life, there may be ways you can intervene from a population or individual level to reduce the risk of developing dementia. And actually dementia is, if we look at people who are, say, 85 and older today compared to a generation ago, dementia is less common in each age group for current generations compared to previous, because these risk factors now do tend to be managed quite a bit better. And also education is going up in the general population. In terms of things that can reduce your risk of dementia, things like Mediterranean diet, physical exercise, hearing loss, which was one of the risk factors brought up, sleep apnea, cognitive training, social engagement. I saw isolation as someone put up as one of the risk factors, anticholinergic medications, and hypertension and stroke. So these are all things that can help prevent dementia. So I think we have our first poll now, which I'll maybe ask to bring up before we transition to the next part of the presentation. So first poll is, which of the following is true regarding the assessment of dementia? We have our options there. Everyone over age 65 should be screened. Neuroimaging should be completed only in individuals with stroke. Caregiver history should use standardized assessments. Or most people with dementia prefer not to know their diagnosis. Which of these would be true? Okay, and can we close the poll? There we go, very good, yeah. Great, everyone. So definitely that caregiver history should include some standardized assessments. I'll talk about a few that you could use as part of that. So in terms of dementia case finding or screening, it is recommended that we do not screen asymptomatic individuals. So you shouldn't, unless there's some reason to have a heightened concern about dementia, should not do just basic screening on everyone over a certain age. People who have functional complaints or changes or new onset psychiatric disorder should be evaluated for possible dementia. Individuals who are known to be at high risk, particularly with neurological conditions like stroke or Parkinson's disease, should be assessed. We should really use validated tests, which I'll talk about, and also include caregiver reported tools, which I'll speak about, things like the AD8 as one example. So in terms of tests that can be used for cognitive screening, I'll touch base on a few of these. I think most people are familiar with the Mini-Mental. It's widely used. It's to some degree, it's been, I would say it's been replaced in terms of evaluation of early dementia by other tools. There's 12 items, it's fairly easy to administer. It is copyrighted, so, there's restrictions around how it's used, but many people have old copies that are kind of floating around or have memorized the items, and so still administer it that way. In terms of its properties, it's neither sensitive nor that specific for dementia. So that means it can miss some cases with dementia, and it can also identify some people as having dementia when they don't actually have dementia. So, it can be a screening tool that is used, but it doesn't have the ideal properties, and it's not that good for mild cognitive impairment. It's also subject to age and education biases. So the two circled numbers here indicate, the top right indicates people with the lowest level of education and highest age, what could be a normal score for them. So a normal score in that population could be as low as 19, whereas someone who is younger with a higher level of education, we would expect them to do quite well on the MMSE 28 and higher. So you have to kind of account for education and age in interpreting scores. Montreal Cognitive Assessment, most people are quite familiar with this. It's a brief measure of cognition. It's a bit better for detecting mild cognitive impairment than the MMSE, and also good for diagnosing dementia. Assesses a number of different areas of cognition. Recently, as I'm sure most of you know, there's some training requirements now for the MOCA to be able to access it. And the information for that is available on the MOCA website. And some of the properties of the MOCA, it does tend to be more sensitive than the MMSE, so it tends to pick up at the common cut points, tends to pick up more cases of dementia, and also tends to be more specific in that it doesn't necessarily over-identify people as having dementia when they don't. And this is sort of some of this cut points or average scores that different populations would have. So normal population could have a MOCA score of 27, whereas MCI and Alzheimer's disease, we would expect to have lower scores. I should note though, like the MMSE, the MOCA is subject to age and education bias. And so you have to take that into account. And in some population, MOCA scores of sort of the low 20s could be normal depending on their age and their degree of education. So yeah, the cut points aren't a hard and fast rule, but kind of general rule of thumbs that you can use in helping to interpret. The SLUMS is another brief screening test, and it's kind of come up recently. It's used for a fair bit in the United States. It's being used a bit more in Canada now that the MOCA has become more limited. It takes about 10 minutes to complete. There's some suggested cutoffs here for mild cognitive impairment in dementia. The original SLUMS, at the bottom of it, there's a story that involves geographic location. It used to be Chicago. In Canada, it's recommended to use Toronto instead of Chicago because it involves recalling the province that the city is in, or the state in the original version. And we use the SLUMS in some of our programs here in Alberta, and I like the SLUMS if I have to use an alternative to the MOCA. And SLUMS scores and MOCA scores tend to be roughly the same. So if you have a feeling what a 15 on a MOCA looks like, a 15 on the SLUMS it'll be roughly a 15 there, or 25 on the SLUMS would be roughly a 25 on the MOCA. So that can be one of the handy things with it as well. You can kind of translate a little bit. It's not exact, but roughly they do line up. And then in terms of informant reports, one of the tools I really like, and which is recommended in our guidelines, is the AD8. And you can Google this and download it. And it's a caregiver report of cognitive changes. So you can hand this to a caregiver when you're completing the MOCA with the patient or in a waiting room. And it really asks the caregiver to check off if they've noticed any of these cognitive symptoms in the preceding few years, things like difficulties with memory or judgment. And it gives you kind of a nice cognitive review. And it's actually fairly accurate for diagnosing dementia as well. So that's a good, easy to use tool to get a caregiver history. So in terms of things that can cause cognitive changes in older adults, I kind of think of primary causes, things that are involved with the brain where there may not be a remediable issue, and then secondary causes, things where there might be something else causing cognitive changes that may have a specific treatment or may be reversible. So our primary causes include things like normal aging, mild cognitive impairment, and dementia, and secondary causes include these potential conditions here. And I know in Dr. Kahn's presentation on delirium, he showed the nice table from the CCSMH guidelines about differentiating between delirium, dementia, and depression. I'm not going to go into this in a lot of detail. I think we have sessions on all of these topics, but just always be thinking about with cognitive changes, whether it may be a delirium, a dementia, or depression. And sometimes they can all three go together. It's not always crystal clear, but these would be some of the more common things that can cause cognitive impairment in older adults. So I'm going to put a question out to the group here before we move on to our next section. What might be some of the questions you'd want to ask a patient or caregiver on history when you're assessing someone for dementia? So what might be some of the things you'd want to ask for as part of your assessment? Great. Great. Excellent. Yeah, these are all great points. I think I could probably stop my presentation and go grab a coffee. You guys have this all in hand here. So in terms of history of cognitive changes, it's important to have a caregiver. I think that's one of the things I saw in the chat there. And also to get the onset and course of changes. You know, most dementias have kind of a gradual onset and progression over time. Other conditions might have more of a acute onset, which would make you think of other things. It's important to ask about different areas of cognition, like memory questions, language, executive functioning, review mental health changes and symptoms of depression, medications, substances, alcohol, marijuana. I screen everyone now for marijuana and CBD because I was seeing a lot of seniors using these substances and it can cause a great deal of cognitive impairment, so really important. I saw in the chat too about family history, and then looking at medical conditions, which can be risk factors for dementia. So this is great. It's also important to do a general medical examination, you know, looking at their vitals, neurological exam. And my neurological exam, I usually focus on signs of stroke or Parkinson's. So those would be two of the more common neurological conditions that could present with cognitive changes. It's also recommended that we have some screening blood work completed. So these are the ones suggested in our guidelines. Maybe other tests that you'd want to do depending on a specific individual's health history. And with neuroimaging or brain imaging now, it's really recommended that this is a bit of a change, that neuroimaging be completed on everyone as part of a dementia workup, particularly if there's the onset of the changes have been within the last couple of years, if they haven't had some neuroimaging. There's also specific times where you'd want to really make sure you had neuroimaging because there could be a high likelihood of something like a brain tumor or intracranial process that may require some specific intervention. But most people should have some imaging done now as part of the evaluation. And they do recommend that MRI is preferred over CT when it's possible. And then I saw in the chat as well about the functional assessment. This is really important. You know, the change in functioning is critical for the diagnosis of dementia. Here's a tool I like to use called the Functional Activities Questionnaire. You can Google this and download it. It's another questionnaire you can hand to a family member with the brief instructions about how to complete it. And it's a nice way for a family to be able to provide a fairly clear history of functional changes or difficulties the individual might be having. And sometimes it's easier for a family member to write this down rather than reporting it in front of their loved one, which can be difficult and sort of awkward. And so I like to use this. This captures instrumental activities of daily living, which are what tend to be affected first in dementia. And usually banking, driving, and medications are the three areas that people first start to struggle with in terms of their functioning. So the diagnosis of dementia, it's a clinical diagnosis, means there's no specific test that can rule in or out a diagnosis, but it's really based on your history exam, testing, and review of functioning. And sometimes you need longitudinal assessments to establish the diagnosis. So our criteria for dementia is now called major neurocognitive disorder in the DSM-5, but it's really a change in cognition noticed by the patient or others that results in some degree of functional impairment, and that it's not caused by something else. So that's a basic diagnosis of dementia. You don't necessarily have to have memory impairment. You could have changes in behavior or language, but you do have to have impairment in cognitive function. I won't spend too much time on here. This is provided to you, but the common types of dementia in older people would be Alzheimer's. That'd be the most common, followed by vascular dementia caused by a large or stroke or several small strokes, dementia with Lewy bodies or Parkinson's disease dementia, which can look very similar, and frontotemporal dementia, which only tends to be found primarily in younger populations. Often, there can be more than one condition contributing to a dementia. So more often than not, it's multiple things, some Alzheimer's disease and vascular changes. So it's not always cut and dry that it's a single diagnosis. Mild cognitive impairment is a stage that most people go through prior to dementia. If someone has mild cognitive impairment, it does place them at high risk for dementia. And for a number of individuals, it can be sort of a pre-dementia state. And really the only difference with mild cognitive impairment and dementia is the functional impairment. So people with mild cognitive impairment do have cognitive impairment, detectable on testing. It's a noticeable change by the person or others, but it doesn't cause significant functional impairment. So just to kind of be aware that that's the difference. It's not always cut and dry if someone has mild cognitive impairment or early dementia. But typically people will go through a period of mild cognitive impairment prior to being diagnosed with dementia. And like I said, sometimes it's not clear if someone has dementia or not. And so sometimes a wait and see approach with observation and repeat testing will help clarify the diagnosis. You can also refer to specialist services or neuropsychologists for further evaluation to help tease that out if you're unsure of the diagnosis. And some of the specialists you may refer to would be like geriatric medicine, psychiatry, neurology, or psychologist, depending on what's available. And all these specialties generally are, quite adept at diagnosing dementia. Just in terms of the disclosure, I'm going to just touch on this briefly, but it is recommended that the diagnosis be disclosed in the vast majority of cases. There may be some cases where people would be very anxious about the diagnosis, where you may want to delay until you can ensure they have enough supports. But it's important to communicate compassionately the diagnosis of dementia. Earlier you can do that, the more independent people can be in their decision making. It's also important to involve family in this process whenever you can, to have the person there to support them. And often you rely on the family to help with following through on recommendations. Just going to skip over this, which is in your slides, but just some approaches that you can use for sort of disclosing the diagnosis in a person-centered approach. And safety assessment, we touched on in the chat as well. Very important after diagnosis. Sometimes there aren't any safety concerns, but the first thing you should be focused on after diagnosis is any immediate safety concerns. Things like household safety, driving, their capacity, or behaviors that might pose a risk to the individual or others. And we won't be able to get into all of these. I think your next session's on behaviors, but it's important to sort of assess these because these can be safety issues for people with dementia. I'm going to talk a little bit about what can be done here in the last few minutes. There's a number of different community supports and things that might be helpful, including referrals to the Alzheimer's Society, programs such as First Link. So that's certainly something that should be recommended for people with dementia. And depending on their needs, other supports and services like respite or home care might be appropriate, but you have to kind of gauge it on the individual's needs. In terms of non-pharmacological treatments, it's really recommended that everyone with dementia exercise regularly, that they're involved in some cognitive stimulating activities, that care partners have education, and that where this is available, that there's a care management or case management, a point person to help coordinate services. And the final couple slides here, just on pharmacological treatment. All people with Alzheimer's disease and related forms of dementia should be offered treatment with a cholinesterase inhibitor. The one exception would be frontotemporal dementia, but for vascular dementia with Lewy bodies, Parkinson's disease, cholinesterase inhibitors can be recommended. All are approved for treatment of mild to moderate Alzheimer's disease. Donepezil is also approved for severe dementia, and they're all the cholinesterase inhibitors are equally effective. So these medications include things like donepezil, galantamine, and rivastigmine. And here's some information about starting and monitoring, just to say that they're started gradually and increased over time to help with tolerability, and they can have some symptomatic benefits for people with dementia. They also tend to be reasonably well tolerated. The most common side effects you would see would be GI upset, which would occur in about 10% of people. And donepezil and galantamine tend to be tolerated a little bit better than rivastigmine on this front. The one condition you have to be careful with is cardiac arrhythmias, which can lead to serious problems for some people with dementia. So sometimes need to have an EKG in advance or be very cautious in people with a cardiac history. And the other treatment we have is memantine or Abixa, which is approved for moderate to severe dementia. It can be combined with cholinesterase inhibitors, but it's not covered under most drug formularies. And so there is a cost associated with it. In most places, it's about $125 to $150 a month. But could be an option for some people maybe who can't take a cholinesterase inhibitor or add it on to a cholinesterase inhibitor if someone has had further decline after an initial response to treatment. In terms of monitoring and follow-up, it is recommended that people have regular follow-up every 3 to 6 months. You don't necessarily have to repeat the testing each 3 to 6 months, but there should be a review of cognition and functioning. In terms of the medications, as long as someone initially seemed to have some benefit in terms of, which usually means a stabilizing disease, then they could be continued on it. But if you don't see that initial stabilization, then it's probably not worthwhile continuing it. And this is my last slide here, which is deprescribing cognitive enhancers. So in terms of stopping the medications, really this should involve a discussion with the family and patient about their preferences. And if the medications didn't cause any benefits or are causing side effects, or if it's really uncertain whether they're having some benefit, they could be considered for discontinuation. Although it should be done very gradually and people monitored to make sure that their cognition doesn't worsen suddenly after coming off of this, or that there isn't a worsening of behaviors. I also recommend now that if people had some behavioral improvement with a cognitive enhancer, even if their cognition has gone down, that might be a good reason to keep it in place, and also to be cautious about stopping cognitive enhancers in people who have significant behaviors, because behaviors can worsen. It might be better to wait until the person's behaviors have stabilized before stopping. So thank you. Hopefully I didn't go over time too far, and I think we'll stop there, and I'll turn it back over to Sid.